Can you hear me well?
Yes.
I will share my screen. Everyone sees that well?
Looks good.
Super. Well, thank you. It's really an honor and a privilege, and greetings from New York. I have a particular interest, and I'll go through that, in the subscapularis tendon. And hopefully once we're done with this, we'll all have a better understanding of what we see as a clinician. Bering, is it possible to undo me as the co-host? Because I'm getting...
Yeah, you're getting all the things. Yep. Let me find you here. There you are. You have, yeah, you're no longer co-host.
Super. These are my disclosures. They're all available on our Academy website. So greetings from New York. This is my view of a sunrise some time ago. But as we all know, if we use a scope, in this case a telescope, we can see things more clearly. And I hope to impress upon you that. So this is the inaugural lecture, and I'm honored that Hillary asked me to speak to you all. We do have a long history. This is on Teddy Roosevelt's summer White House porch, and our friendship goes back quite some time, and something we in our family and the Ewens family greatly appreciate. I'll go through these steps with some history, why it's important, some clinical concepts, how to repair, review some principles, and then maybe give some correlative arthroscopy, MRI case examples. And the images on the right, we'll revisit later when you have a better knowledge. From a historical background, the first report of subscapularis tear was by Smith in the London Medical Gazette. About 100 years later, Codman in the first ever shoulder textbook described this tear. McLaughlin from the New York Orthopedic Hospital at Columbia, where I trained, discussed it related to rotator cuff tears, but also shoulder instability. One interesting side note, if you look at this photo, this is McLaughlin on the left and Charles Neer on the right, who undoubtedly was influenced by McLaughlin. In the early 90s, Christian Gerber really brought it to the fore. The clinical concept and the importance of identifying subscapularis then arose from there, first as an open and then an arthroscopic technique. A connection to that, this is J.P. Warner on the left and Christian Gerber on the right, and J.P. is one of my mentors, and I'll explain further. I had the good fortune of training at Columbia, and another one of my mentors, Lou Biliani, is on this paper, my first foray into the subscapularis. J.P. Warner and I again then published our work and in a technique manner on the subscapularis and other single tendon tears. And from there, I've been interested throughout my career in the subscapularis. Here's JP on the left. I thought I'd go through some general basic principles of shoulder arthroscopy to orient you. This is a right shoulder viewed from above and behind the shoulder. You can see the camera from the very bottom of the view and two cannulas through which instruments are introduced. And this is what it looks like on Tuesday. Sorry for the little bit of flood, but this is the camera I'm holding in my hand at the bottom, a cannula on the lateral aspect on the right, and the anterior portal is noted. This is more of a lateral view of the same setup. Here, looking at a supraspinatus tear. This is what it looks like from the outside. And we'll do more arthroscopic views as we progress. And just to orient you, the subscapularis is here in the front, the biceps, supraspinatus, which is the most common tear. And here we have infraspinatus into the teres. Why is it important to repair the subscapularis? So let's lay the groundwork here. I'll show you one patient. This is viewing from posterior in the left shoulder. some landmarks of the coracoid and the empty or bare lesser tuberosity. This is the coracohumeral interval. This is the conjoined tendon, which includes the short head of the biceps. And what's missing here, again, the conjoined tendon, is there's no subscapularis, as you can see here. This is after the repair in this patient. It's well attached securely, and these are the same areas. So that's what our goal is, an anatomic repair. The video of the same patient, you see the greater tuberosity in the biceps tendon, and we'll go from lateral to medial with the arthroscope, the dislocated bicep, and it can dislocate because there's nothing here. The subscapularis is torn and retracted more medially. We then go and try to identify that, place an instrument through a lateral portal, just grab on it, and now we can start to see a couple of important structures, the rolled edge of the subscapularis, and this tissue, the confluence that connects the supraspinatus above and out of our view with the subscapularis called the comma tissue. It's originally described as a portion of the superior glenohumeral ligament, but it's even more, including a portion of the roof of the over the biceps. I've now placed a traction suture, and I can now pull a little bit more on the subscapularis. And what that reveals is this structure, the middle glenohumeral ligament. In normal circumstances, this is lateral to the glenoid face, and I use that as a guide to what needs to be repaired. If I cannot see the middle glenohumeral ligament, I'm more than likely going to repair this subscapularis, as you can see it here under the arrow. And for me, this is level 5 evidence, but this is a structure that helps me identify tissue as well it needs to be repaired. I am going to release this as part of the surgery, however. Just another example, this is a right shoulder viewing from posterior, the glenoid on the left, the humeral head on the right. The probe is showing the leading edge of the comma tissue. I hook into the subscapularis, bring it laterally, and here is a diminutive middle glenohumeral ligament. So back to our patient AD. I'm now viewing a little more laterally, and above you is the supraspinatus, right over the humeral head. And what I'd like to see now, you can see the supraspinatus is coming more laterally as I pull the subscapularis more lateral. And that's an essential feature. If we view the same patient now through the lateral portal, anterior is on your left. I'll give some more landmarks here. There's the glenoid and the greater tuberosity, the supraspinatus and infraspinatus. If we pull the subscapularis again and view in this location, we're going to see the tendon is going to come over the lesser tuberosity over here and bring the posterior superior cuff more laterally. That's going to help me with my repair. So this is before and this is after. So I'm able to get a much more secure repair. And again, the essential feature is that confluence between the subscapularis and the supraspinatus called the comma tissue, as you can see in these drawings. Viewed from the front, if you don't repair the subscapularis and only repair the supraspinatus, it's akin to only closing your zipper halfway. It's more likely to re-tear. However, if you do repair the subscapularis, you do that first, you bring the subscapularis into a good position, you'll also translate the posterior superior cuff more laterally to effect a more secure repair. And it's because of this comma tissue. And Steve Burkhart and I published this some years ago in Arthroscopy. The clinical approach, early diagnosis is important. This is a patient I saw after an acute subscapularis tear. And this is him, I recommended surgery. This is him 9 months later. The tendon retracts, you lose the wavy appearance of the acute, of the tear. Here you can see it. Because you want to avoid a late diagnosis with an irreparable subscapularis tear. Then you want to mobilize the tendon. This, you can see the coracoid in the upper part of the view, and then the subscapularis, so that you have good lateral translation of the tendon. Then you want to do a secure repair, and I'll go through that in some steps. This is a left shoulder viewed from posterior, the same repair viewed from anterior. And I use a single row repair technique and tie knots. This is another repair, an internal external rotation. You want to stress your repair to make sure it's secure. And then you address associated pathology. This is a supraspinatus and infraspinatus repair that you secure down. Just to give you some perspective of how prominent and prevalent subscapularis tears are, this was some years ago, a consecutive series that I collected. And in those 74 patients that I brought to surgery for an arthroscopic posterior superior repair, 31, so 42%, a significant amount had subscapularis pathology. Of these, more than half required repairs, in my opinion. The tears can vary from partial tears on the upper row to full thickness tears on the lower row. There's also a significant amount of biceps pathology that I encountered, often related to the subscapularis, but also the posterior superior cuff. Of the 6 ruptured and 4 dislocated biceps tendons, all were associated with subscapularis tears in this small series. And many more required treatment, a majority. So if you look at this, and this is a series that was brought to surgery, not just all comers, 2/3 required some subscapularis or biceps treatment due to the pathology. So let's talk about the biceps. It's not the focus of this talk, but you can't talk about the subscapularis without referring to the biceps. This is what it looks like in a right shoulder of a dislocated biceps. It's from the superior glenotubercle out of the view. It projects almost vertically. And here you can see the frayed, fibrillated portions of the biceps as it rubs in and out of the groove. This is a subluxed biceps. This is a right shoulder viewed from posterior portal. You can see the edge of the left tuberosity with the yellow arrow. The biceps groove is pointed out, and the flattened, widened biceps tendon that's wearing on the bone. This is that same patient a little more medially, and it can do this, it can sublux, because there's no subscapularis tendon more medially. You do have to take care of the biceps and treat it and figure out what you're going to do early, and then move on to the subscapularis. There are times where I'll do a tenotomy or a tenodesis, depending upon the patient and the preoperative discussion. So once you've addressed all the pathology, a controlled rehabilitation is important. All of those are on my website for any further interest. In the clinic, a detailed history can often suggest subscapularis tear with trauma, forced external rotation. It's more common in males. A directed physical exam, as in this patient, has increased external rotation in the right shoulder. Weak internal rotation with the belly press, so the left is the normal, the right is the abnormal, and the elbow cannot stay out to the side. There's also the lift off. This is the normal, so the hand is in the small of the back and they can lift it off, and here the patient can't. There's a modified lift off where you hold it off, and if they don't have a competent subscapularis, it slaps against the middle of the back. Of course, you'll have to look for the biceps and posterior superior cuff pathology during this exam. X-rays are not as helpful. You can occasionally see a coracoid non-union or a cyst adjacent to the left tuberosity, but the most important thing is the MRI or CT. Here you can see the axial cuts, which is the more common view that shows this well. Other patients with biceps and subscap, including a left tuberosity cyst. For me as a clinician planning surgery, there's a lot of value of the MRI, and I'll go over that. This is one particular patient. Another, you can see on the left, the wavy nature of a more acute tear. On the right, the completely detached subscapularis, the dislocated biceps, and the middle glenohumeral ligament right here. Sagittal views are also helpful, particularly in the anterior-superior tears, as in this case. But I find the coronal view is actually very interesting and helps me understand the tear pattern a little better. Just want to review what a normal subscapularis looks like. You can see on these axial and coronal cuts, the muscle abuts the medial aspect of the coracoid. And that's normal to see. So back to our patient, you can see the supraspinatus tear. I also look at the quality of the muscle, which is certainly decent in this case. I want to look at the tendon stump, which has been reported 15 millimeters or more is ideal for a secure repair. But if we look a couple of cuts and more anteriorly, we see some other interesting features. To me, if the subscapularis is torn or retracted medially, there's going to be a void. And that's shown here under the arrow, medial to the coracoid. So for me, that's I just refer to as a medial coracoid sign, because we know that should abut quite closely. Again, this is level 5 evidence, but it helps me appreciate the tear pattern better. We also see the vertically dislocated biceps, and I believe this is the comma tissue, which is, if we followed it, would lead you to the supraspinatus tear. Some other interesting features that I need to know when I'm planning surgery: is there a footprint cyst? Not only is it important from a clinical standpoint, but where am I going to put my anchors? I don't want to place it in this location. I'm going to have to figure out where to go around it to get a secure repair. You can also see the biceps tendon in this patient on the left is perched. On the right is also perched to dislocated. And another interesting feature, which Hilary Humans and I looked up and submitted to SSR, is what we've called the os subscapulari. We've not seen it published. But here's an ossicle, as you can see, along the anterior aspect of the humeral head. Here it is on MRI. And in our entire series, a small case series, all of these were associated with subscapularis tears. This is what it looks like in the patient. And then you can repair it down. You can actually get bone-to-bone healing in a secure fashion, in an anatomic manner. There are many classification systems. I don't refer to them as much. There's some that mix arthroscopy and MRI, some that are just arthroscopy, but they are out there for your reference, and they're also in the article that you all received. Hidden lesions are important to identify, and I'll go through what this is referring to, and I believe Gilles Walsh pointed this out some years ago. You're looking here at the biceps tendon into the groove. To your left would be the subscapularis. You can see a little fraying under the biceps, which we would typically leave alone. But as you go down into the groove, anterior to the biceps tendon, you're going to see a small defect. This is the so-called hidden lesion. This is a very small one, but I can't imagine it's going to get smaller. It's only going to get larger. Here's another case where a seemingly innocent split in the subscapularis, but if you internally rotate and then look through that split, more laterally, you're going to see the biceps tendon. This requires a treatment as well. Here's another case, excuse me. You can see the subscapularis, the biceps tendon, and as we retract it more laterally, you can see wear under the biceps, but then you see the exposed footprint of less tuberosity. On the MRI of that patient in the coronal view, there's not much that would lead me to think about this. However, if I go from medial to lateral in the sagittal views, following the biceps, maybe here you can see the exposed less tuberosity footprint. I also have the advantage of being able to palpate the patients to identify where they have their tenderness, to know where to look. And here we are, the biceps adjacent to the subscapularis, and this certainly could suggest that deep surface tearing. And again, this is that same patient, and this is the feature that we don't want to miss at arthroscopy. So you got to look down the biceps groove to identify that. So in the OR, there are different repair approaches. When I first started out, it was all open, and now it's all arthroscopy. Here you can see an anchor being inserted, the sutures available in the lateral aspect of less tuberosity. I'll show you some short videos on passing the suture, and then here a secure repair. So there's nothing wrong with an open procedure. This is my last open case in 2008, and the patient did quite well, so it can still be a very good option. I do think you can see more and actually do more with arthroscopy. This is some years ago a setup that I typically use. It hasn't changed much. That allows me as the surgeon, my PA assistant, and a surgical tech. Here it is viewed from another angle, so I can see the camera and work around the right shoulder. This is a month or two ago, so nothing's changed except more modern technology, and of course the COVID mask. So I'm going to go through this one patient in a stepwise approach. This is MRI, so you can appreciate he's got a subscapularis tear as well as a posterior superior cuff tear. This is a right shoulder viewed from posterior. And as we retract, here's the common tissue. You've seen this video once before. I'm bringing the tendon laterally. This is how much I'm going to have to repair it onto less tuberosity. So this helps me understand what my goals are. And again, there's the middle glenohumeral ligament. You want to be able to expose and visualize the lesser tuberosity, which is in the lower part of the screen here. Sometimes it's not as easily visible, but it is fully exposed. This is a complete 100% tear. So if you can't see it well, if you simply flex the arm, you can expose it much better. You've got to remove the tissue in the rotator interval so you can work on both sides of the subscapularis. Here, one landmark is to look for the coracoid tip, which we'll be able to see right over here. And this is a wand that helps ablate soft tissue. Then we want to make sure we have a plane. This is posterior to the subscapularis. We'll go out into the subacromial space and then go anterior to the subscapularis to create a working space around the tendon. This is another patient where you can see the space anterior to the subscapularis. This is viewing from lateral, and this is viewing from posterior. And they'll all have enough space here to work past sutures and tie knots. So again, this is the area that I'm looking for. Here's the coracoid tip and the coracoacromial ligament. Sometimes you can identify the axillary nerve. You know it's there, don't go looking for it. This is the coracoid. We're looking more medially and inferiorly over the subscapularis. I'll need to approach the tendon and create a cannula. So I'll place that. And then I want to put in my traction suture. This is a device that can penetrate through. It's about 2 to 3 millimeters in size, so it's a small hole. Then I'll feed through a monofilament suture, make a small stab incision laterally, and bring this out through that stab incision so that I can control the tendon. Here's what it looks like exterior in this right shoulder. The head is more medially, and those are two cannulas. This is that same patient. Now I'm viewing through the lateral portal. The anterior labrum, humeral head, and subscapularis are identified. And then you want to release the tissue to the base of the coracoid, which you can almost see. This helps control bleeding as well as remove soft tissue. Again, at the top part of the view is the coracoid, which I'm underneath. And in this case, it was fairly straightforward to release the subscapularis. Sometimes it's not as easy as in this case. There's more scar tissue that you've got to release. Using this device helps control bleeding at the same time. But the goal here is to make sure it's free and mobile. You can see under the coracoid there. And then we release around it so it is in a good position to be repaired. This is our same patient with a complete release. If you look into the depth, you can see the vessels beating. but then want to check around the subscapularis, anteriorly, superior, and posteriorly for a good release. Then check your mobility. And again, pull on the traction suture, make sure the tendon is fully mobile. Now again, viewing from the posterior portal, you have to prepare the bone upon which you're going to lay the tendon of the subscapularis. So you want to denude the soft tissue. I've done most of it. Here I'm just cleaning it up to have a healthy bed for the tendon to lay on and heal to. I'm going to have to place anchors. You can use other techniques like tunnels, but in this case, I'll demonstrate a single row anchor technique, one more inferior, one more superior on the lateral aspect. You can also come from more lateral. The wand is in the biceps groove. I'm releasing scar tissue here to expose the inferior aspect of the lesser tuberosity. And I'll insert anchors. There's a spinal needle showing the approach. And if you externally rotate the arm slightly, you can place it in a good position. Here's the anchor sheath. The anchor is in here. And there's that same view, so you can see this coming through the skin, but you can also go through the cannula. As I'm showing here, you can see the cannula here. You impact the hole in this case to place a peak akin to a plastic anchor, and there are the sutures where you need them. Now I got to pass the suture. This is one of those os subscapular. The tendon avulses on an angle, on this angle. So you want to pass your sutures around in this fashion. So that's why I use this type of a device, which allows me to do that. Hold on a second, let me go back to this. So I'm coming in through the anterior portal, again in the right shoulder, viewing from posterior. I'm about 2 centimeters down and 1.5 centimeters medial, and I'm passing this monofilament suture, which I'll then use to shuttle one of the repair sutures from the anchor. I'll do this for all the sutures in the anchor and space them out from inferior to superior. Let me go to the next one. And then I'll tie through the cannula with an arthroscopic knot tying device. I've internally rotated the arm, and this allows me to bring the tendon directly up to the anchor. And this is after I've placed both anchors, passed all the sutures and tied them. And here it is in a good secure position. I'll externally rotate it and stress the repair, make sure it's secure. Now I know my limits for my rehab to begin with. And if you remember, this is that same patient. So I believe I brought this tissue where we need it to be. Here he is at 6 months postoperatively. Still weak, but with good motion. I ended up doing his other shoulder, which had a similar tear. There are partial tears that are fairly easy, but sometimes you don't identify them. This looks seemingly normal on a left shoulder viewed from posterior, but if you internally rotate it, you're going to see this significant partial tear. It's thin, so for me, this is one I'm going to want to repair. Remember, I'll use a similar device in this angle to pass through. I don't want to pass it in any other angle to get a nice secure repair for this patient. This is a full thickness tear repair of about 25% tear. In a left shoulder, you can see the humeral head below, the anterior labrum just on the right. So I'm going to want to expose the bone and then repair the tendon down to it. I've already inserted the anchor. I'm now going to shuttle my suture through the tendon. Then I'm going to do one suture at a time, and I'm going to tie them to bring the tendon back where I want it. To a slightly larger tear, I have the MRI on this patient. You can see the detachment of the subscapularis. What I look for, more fluid medially. Here's the biceps involved. Here you can see it, the posterior viewing in the right shoulder and the anterior cannula. I only need one cannula for this particular repair. And you can see the biceps is perched on the edge of the less tuberosity. And as I go around, I can see the fully exposed less tuberosity for this, but it's about 50% tear. You could argue it's a little bit more, but for me, it requires one anchor that's triple loaded. I passed all 3 sutures through in the technique that I described to you. The lateral sutures I also passed through. But now if I'm working with one cannula, I've got to remove the sutures so that I can have just one at a time in my cannula. So I use another suture for that. And I bring the sutures out the cannula or back in the shoulder and then out of the cannula and up through a puncture in the skin. Here we have it. And then I'll tie each suture one at a time with the arm in internal rotation. This is the first getting started. And here I have my completed repair in neutral and external rotation. This is viewing from the anterior portal. You can see the knots in place. And here he is at 7 months with a good outcome. You can have adverse events. We had this discussion with every patient for surgery. Re-tears in my hands, I've seen very few, but this is a patient 4 years later reaching for a softball. The anchor pulled out. I just removed it. I've not had a neurologic injury, been very fortunate, but I know where the nerves are and you have to always respect them. Infections can happen. Stiffness is not uncommon after any type of rotator cuff repair to some degree. But typically, the one thing I tell patients is strength deficit. The longer the tendon is torn, the less likely they're going to get back their strength. And I never promise 100% return. So some principles as a reminder for what we went over. There are diagnostic findings that I look for. The MRI we went over, and I'll show one or two more examples. Here is the comma tissue. When you expose the rolled edge of the subscapularis, you see it, and as you retract it more laterally, here's the middle glenohumeral ligament. I do a single row repair. This is an older repair with 2 metal anchors, so I can show you these in the lateral aspect of the less tuberosity, one more superiorly, one more inferiorly, but that's about the location of them. I use a retrograde suture passing and shuttling technique. There are other techniques, including anterograde, that you can use to get a secure repair. Once you're done, you want to address any associated pathology. This is a supraspinatus into the infraspinatus, about a medium-sized tear, a medial anchor. The sutures have been passed in the same fashion, brought to a lateral anchor for a completed repair. And then the controlled rehabilitation. These do take time. I'll tell patients, 4 to 6 months. If it's a 100% full thickness complete tear, definitely at least 6 months. And my protocols are available, as I noted. So let me give you a case example. This patient AS, these are my x-ray views that I get on patients, an AP and an outlet, and then an axillary and a Zenka view. Here are the coronal cuts. We've discussed some of the interesting findings. You see the fluid around the biceps. You can even see the comma tissue. The subscapularis is medially. These are the sagittal cuts, where you can see the biceps draped over the less tuberosity, and then the less tuberosity is bare, and the confirmatory axillary images where the biceps is dislocated or subluxed, depending upon the view. And this is what we see in our patient. This is, again, viewed from posterior. Here you have, in this right shoulder, the comma tissue. I'll hook. The subscapularis is now coming into view. And if we retract it a little bit further, now we see the middle glenohumeral ligament right here. Viewed more laterally, same patient. Here's the biceps. You can see it here, actually subluxed. I'll go along, portion in the biceps groove, portion on the less tuberosity, but there's no subscapularis tendon more medially. Just wanted to have it as part of the talk. This is an article which would describe some of the things I've mentioned. And this is what I went through. So I'm going to go back to these images on the right. I think now that we've gone through all this material, you might be able to tell me what the MRI in this patient will show. So clinically, through arthroscopy, the biceps tendon is dislocated. Here's the subscapularis and the humeral head. You can see the anterior labrum. We can even see the comma tissue here, which is more readily apparent with the biceps retracted out of the way in this view. So the MRI, we know what it's going to look like. This is, by the way, the lateral edge of the subscapularis. Here we've got a vertical biceps tendon. Here is a posterior superior cuff tear in this particular patient. You can see the biceps already going in a more medial position. Here it is with the tear of the subscapularis. So this is a dislocated biceps. But here on the sagittal cuts, you can see the bare less tuberosity. And to me, this looks like what is the comma tissue that we saw. As we go more medially, it becomes more confluent with the subscapularis. So again, in the same patient, if we retract the biceps out of the way, right shoulder viewed from posterior, we can see the comma tissue up to 12 o'clock, the subscapularis going towards 8 o'clock, as we would have expected from the MRI. So I hope that was helpful. Thank you. I guess we have time for questions from this point forward. I guess I will stop sharing. Okay.
If anyone has any questions, please raise your hand and we will call it. The chat box is also available for audios.
Well, at the very least, I think there's a lot of information that is coming out about subscapularis over the past 20 to 30 years. It's really come to the fore. So I know that as radiologists, you're looking for this, but it's quite common, much more than you would have thought if you were a shoulder surgeon in the 70s and 80s.
I have a question.
All right.
So you said in that series you did of, I think, 74 posterior rotator cuff repairs, that 42% were torn, and that was a combination of partial and full thickness tears. But only a percentage of those warranted repair. How do you decide at arthroscopy what requires repair and what doesn't?
So again, if the medial glenohumeral ligament is retracted and I can bring it laterally and then see it, that's one indication to me. If the tear is very small, and I showed some of those pictures, and I can just debride them, I do, particularly if the biceps has no compromise. And that's the general gist. If on clinical exam there's no subscapularis findings, they have a normal belly press, I can correlate that. I have a distinct advantage. I can see the patient, touch the patient, examine the patient, whereas in your hands, you're just looking at the images. And you have a far greater knowledge of that, but I get to put, my limited imaging knowledge and correlate that with the clinical exam. So I can make that decision preoperatively. Just like with partial tears of the supraspinatus, if they're just a few millimeters, you debride it, and as long as the biceps is not compromised, those you can leave alone. Since that time, it's usually in a 1 year period when I look at my cases, it's about 30 to 40% have subscapularis pathology, and somewhere between 45 and 50% have biceps pathology in my arthroscopic posterior superior cuff tears. And not in a COVID year, but I can have over 150 cases, and that has been a pretty good number for me to anticipate in my patients.
Okay, I have additional questions. I don't want to be an askaholic, but I don't see any other questions in the chat, unless Bering, do you have other questions? I'll just plow ahead. You said that by repairing the subscapularis, you laterally retract the posterior superior cuff via the common tissue, and it makes for an easier and better repair. Are there surgeons who don't routinely, are there surgeons who don't routinely repair the subscapularis?
I'd like to think there aren't, but I do know that it is more technically challenging to do this. And in fact, when I see a massive rotator cuff tear of the supraspinatus, infraspinatus, when I see a subscapularis tear, I'm actually a little bit more heartened, because now I know if I can get the subscapularis, it's going to make my massive repair easier. So I know it's going to take me 30 to 45 minutes longer for the case. But for me, I'm happy to see that because I know it's going to make the tear a little bit easier. I won't say I'm happy to see it, but if I do, I know it can be useful for me. Yeah, I would suspect that there are some surgeons who don't or have different indications, to do a subscapularis repair. This is not, fully codified. So there is some expert opinion on when to proceed and when not to. For me, my first arthroscopic subscap repair was in 2001. So I've been doing it for quite some time. So for me, it's fairly easy. And I do have a good background and knowledge of the tendon and how to repair it.
What if you can't, you show that you release the tissue under the coracoid and you see that you can pull it out to the lesser tuberosity. Is there ever a situation where you can't get it to the footprint where you want it?
If you can't get it to the anatomic position, you can always place it a little more medial. We do the same thing with the supraspinatus. If I don't think I can repair it, hopefully I've had that conversation yesterday in the clinic. I had the same conversation with a patient. 7 years ago, I had a subscap tear, which another surgeon elected not to repair. If he does elect to go to surgery, I don't think I'm going to be able to repair it. So we can do, there are other options, but at the very least, I'll address the posterior superior cuff and the biceps. It's not ideal, but those are the circumstances. So there are some that I can't repair, and rarely I'm there and I can't repair it. So I address those structures that I can, but it's not been common.
My last question actually relates to the imaging, the preoperative imaging, and this is not a reflection on the radiologists who read your studies, but based on the literature, and I assume much of the audience knows, that musculoskeletal radiologists are not as accurate at identifying subscapularis tears as we are at diagnosing tears of the posterior superior cuff. So, I mean, there's a literature, and the numbers vary, enormously about what our sensitivity and specificity is. But in your just day-to-day experience, do you find that these subscapularis tears are identified less frequently than the posterior superior cuff tears, or is it getting better?
It's getting better, but yesterday in the clinic, I had a patient who had clinically a complete subscapularis tear. He was unable to do the exam, and the imaging report was a high-grade partial tear. I can't say that to me, it looked like a full thickness tear on MRI, but I'm looking for different things. But it's definitely getting better. But I don't look at reports. I look at the MRI images, and all my patients bring them in. And I won't take them to surgery without me actually seeing the films, so that I can understand and appreciate the tear better. I do see some questions in the chat, which I can refer to. I do use different portals. The two angles I view from posterior and I view from lateral. I do all of my subscapularis repair in the glenohumeral joint. There are people who do it in the subacromial space. I don't find that to be as helpful, but that's easily done by other surgeons. So you don't necessarily need to do it in the technique that I showed. This is just one technique. So I do look at it from different angles because I want to see how the tendon's coming, but mostly from posterior and from lateral. And then the decision between tenotomy and tenodesis, that's a whole nother 15, 20-minute talk, but it depends upon how much the patient cares and I care. The older the patient in the 70s who I can do a tenotomy, I would try to suggest that to them because clinically it's not that much of a difference. There is a deformity. Someone who's 50 or younger, I'll suggest a tenodesis. I'm able to do tenodesis in about 4 different ways, so it depends upon how I see the tendon. But that is a discussion that I've had preoperatively with the patient, because I know in half of my patients I'm going to see something with the biceps. In my subscaps, it's going to be almost all of them something with the biceps. So those are the discussions that we have before surgery. If the tenodesis is not going to take away from the rest of my repair, because the shoulder does swell and you have only so much time, then I'll incorporate that into the repair at times. I hope that answered your question.
Okay, looks like no one else's hands are raised, so, and nothing in the chat box. Last call for questions.
So I just want to thank you all for coming. I want to thank for the opportunity. This will obviously be available for others to view. And I think you're doing a wonderful thing to have this cross-fertilization between specialties. We certainly can learn a lot from what you see and what you think is important, as you've given me this opportunity to share with you today. So thank you.
Thank you so much for taking the time to prepare this and translate your images so we could understand what you're looking at and see through your eyes. Thank you.
All right, and Baron, thank you very much for moderating and managing.